So, yeah, thank you everyone for coming to our community meeting. And those of you who are watching recorded on integratedcarenews.com. The community conversation that we're going to have, first of all, what are community conversations? We just kind of get together to have conversations in a relaxed fashion that allow for members to converse with each other, network, talk about issues in a non sort of webinar fashion. We try to keep these things open, light, and really relevant. And so often what we do is we take a listserv conversation or something that our organization is thinking heavily about, and we talk about it with our members. And this particular conversation definitely comes from an ongoing longitudinal conversation around screening processes, the role of technology in screening, and the utility of screening in our primary care settings and other settings as well, community mental health settings, addiction settings, et cetera. We pretty much regularly have these long threads on our listserv pretty much every year. And one of the ways we really want to change the conversation is to sort of deepen it with a little bit more nuanced understanding of what screening is, what its purposes are, what the tools are that can help, and what really makes screening potent, and what can hamper screening efforts. Now, what we're going to do today, we asked a few CFHA members who are connected with solutions around screening to present a few minutes, 5 minutes max, we set, on particular screening solutions and their perspectives on screening. And we've got 3 really great videos to show you. So we're going to show those videos here at the outset, and then we're going to launch into our conversation. However, during the videos, as they're playing, if you have like thoughts, questions, comments, just want to interact on the chat, please go ahead and put things on the chat as we go. Before we show the videos, I want to tell you a screening fail story of mine, just to kind of get us going, and to also just let you know that I think one of the themes that will come of this, and you'll see these in the videos, is that screening is something that you have to be very intentional about. And in fact, one of the things we'll talk about right after as an initial question following the videos is the notion that really screening involves organizational change. And if you treat screening as something that's sort of extra organizational or just some sort of little side project, that's when you're most likely to fail at your processes. So here's my fail story. Now, this is about 20 years ago. I was working at an FQHC on the west side of Chicago, and there was a foundation that was looking to give our organization some money. And I had for a long time wanted to implement some sort of universal screening related to behavioral health integration. And I'm a huge tech aficionado. So even then, remember, this is the early 2000s. So touch screens and things like that were still really, really pretty new, especially touch screens as we think about them today. And so I had this idea for a screening solution using the Duke Health Profile to screen our entire population, or at least a substantial subset of our population, at the front door of our community health center there on the west side of Chicago. And so I concocted this idea. The funder gave us a little over $20,000 to implement this solution. We had a touchscreen computer on this very nice cabinet that cost us a chunk of change. We loaded the Duke Health Profile on there and then put it at one of our clinics. And lo and behold, the entire process collapsed pretty quickly. My vision was that people would come to the front, register, get sent over to the kiosk, answer the questions on the Duke Health profile. That would then send a report to the back to the printer on the back, and give the clinicians a heads up related to any concerns ahead of their visit with the patient. Now, there are all sorts of things that went wrong with the process. Some of them were tech related. We had trouble aligning our EHR and the identification ID of the EHR with an identification on the kiosk and the computer there to match up the screener with the patient. We had problems just printing to the back consistently. We had some employment or HR type issues, I would say, right? Because I hadn't coordinated with the directors of the registrars. The registrars were very spotty with how they sent people over to the kiosk to get their screeners done. And in fact, what I thought were simple instructions turned out to be very difficult for the registrars to give to the patient so they could know how to input their ID number into the kiosk over. So we ended up getting very few of these ever accomplished because the registrars simply weren't able to send the patients over the kiosk effectively enough. And then on top of that, on the back end, we figured out that the providers really didn't find the reports terribly useful. And so even if they happened to glance at the printer for this piece of paper before their visit, what the information they got, they didn't find terribly useful. So I hope that gives you a sense of what we're about to see and why some more advanced solutions have been developed in the 20 years since that story. We're going to start off with a video sent in by CFHA member who's here today, Alan Malik. So Alan's, one of the things that that Alan does very well in this video is he really talks about how a key to effective screening is process automation, which you can tell in my story I didn't do very well at, right? Process automation. And then just keep your ears peeled for when Alan talks also about CJ Peak and the three-world view, because that really gets at this idea that screening is an organizational change process that affects the clinical, financial, and operational. So without further ado, let's roll Alan's presentation.
Hello, I'm Dr. Alan Malik. I'm with Patient Tools out here in Littleton, Colorado. And I wanted to respond with maybe a slightly different perspective on how to do a screening solution. In this particular arena, what we're trying to figure out is what is appropriate level of screening, how do you use assessment. It really isn't an issue of screening versus assessment. We kind of get worried about sensitivity, trading off with specificity. There's a bunch of stuff in here about how to systemically solve problems. So you're trying to meet the requirements of the United States Preventive Services Task Force. And then the reality is you have to implement in a medical setting. So you really need to be paying attention to CJ Peak's three-world view. And so I would say that I'm not sure that you're really framing the problem the way you really should. And I would say this is more just a process problem. So let me explain how that goes. So let's just grab some data real quick. This is basically as a FQHC up in Montana. We went in and we were actually checking out a PHQ-9 relative to a QPD, which is a quick psychodiagnostic panel, which is a computer assessment. And we were basically dropping in, the PHQ-9 in with the QPD and trying to see how they interact and so forth. So there's your underlying population. Real quickly, this is what the QPD looks like, and all the breakouts on it and so forth, but it's basically a quick psychodiagnostic scan, and it was designed originally for medical settings to go to medical providers to try to get them into the behavioral health world. And then the big thing you got to think about on sensitivity is, yeah, the PHQ-9 has its sensitivity issues, but what you're really looking at is process sensitivity. And so what you're really looking for is what happens if I use the PHQ-9 as a trigger for the QPD. what gets missed, what gets picked up, and so forth. And so you can run through the numbers here. But the big thing that goes on here is that, you know, false negatives hurt the patient, false positives waste the provider's time. So if we pop forward, break those out, well, you see the problem here is that, you know, PHQ-9 is depression. Well, you know, when is depression actually depression, and when is depression a symptom? And so if you just look real quickly here at major depression, dysthymia, and not otherwise specified, about a third of the time it actually is depression. But more importantly, what you want to really be seeing are things like bipolar and PTSD and so forth. So the idea here is that you can do in-depth to get to your specificity from a process perspective. And from a process perspective, you probably actually want to be looking at more than just the PHQ-9. What you're actually seeing in this data when you see the stuff that's being missed is it's a lot of it's anxiety based. So if you're using like a PHQ-2 and a GAD-2, might be a much better pre-screen for some sort of computer assessment. Then cost. The biggest thing you need to understand here is that every time you trigger something in your pre-screen, somebody has to follow up on that, and they have to spend time to do it. Where if you were doing that automatically, then you would just save just tons of time and so forth. And ultimately, you can make screening a profit center if you really work it out right. So in CJ Peek's 3-world view, it's clinical, operational, financial. And so you can look at all those different breakdowns there and so forth. But the whole concept here is that to be effective, you want to automate your screening process. So what all this comes down to is that in practice, your screening solution wants to be process automation. So you need both screening and computer assessment. You want to go for breadth for the process sensitivity. You want to go for depth for your process specificity. You can use the QPD, CAD-MH. We find a lot of people are using what we call an integrated public domain screening, but basically you gang a bunch of measures together, and there's a lot more efficient ways to do that. Self-report in clinic, or we find now, especially with the pandemic, a lot of remote screening via links or in an email or in a text. It actually works really well. And then you have to be automated in your integration with your EMR. So you actually initiate all of your screening from when the visit gets scheduled. It comes out automatically. And then when the data comes back in, it's just lab data. And most people have to bring it in as summary notes and a report because that's generic enough for most systems to handle. So end of the day, you meet all of CJ Peek's requirements with the automation, and you solve all of your screening sort of issues. So process automation is the answer you're looking for. There's my email down there. Let me know if you'd like to explore further. Thank you very much for your time.
Yeah, and thanks, Alan. And Alan is certainly on the call to answer any questions as we go. But what you see is that compared to the solution that I came up with 20 years ago, there's a much deeper level of integration there with the processes that occur at the point of care, including some thinking about what are you trying to do with your screeners, right? So that's where that question is, well, is a PHQ sufficient to use as a trigger for a more in-depth tool? Or we've had lots of conversations on the listserv, do you just do a whole PHQ-9 instead of a PHQ-2? But even beyond that, maybe what you're really looking for is a screener that's either transdiagnostic or is multi-condition, right? Those are important questions to ask that relate specifically to the utility of what you're going to get out of a screening process. And that, and I'll say this before we move on here to the next video, that's a question that you in behavioral health, if you're working in behavioral health, you're not the only one that should be answering that question. That's something that your entire team needs to be answering. What is going to be useful to us as a team about that process? That's one of the errors I made. I made assumptions about what our team and our patients needed. I didn't involve other people in that. I chose an instrument that then didn't have the utility that the team could identify as valuable. All right, so we're going to go on here to our next video. And in this video, we're going to see another CFHA member, Javier Rosado. He's not going to be talking on the video, but he's the originator of this system called the Multilingual Automated Screening System. Here you're going to see something a little bit similar to what I came up with, but a lot better process. as far as a point of care kiosk-based screening solution. So let's roll that.
The multilingual automated screening system, also known as MASS, is software designed to facilitate automated and routine behavioral health screenings. MASS was created by a group of researchers at the Florida State University College of Medicine Center for Child Stress and Health. The software is specifically designed with features to facilitate screenings with patients of varying reading and computer literacy levels and for non-English speakers. The software is an interactive touchscreen assessment tool that has a configurable question set that supports multimedia and one-to-many different languages. These can be updated and customized to fit the changing needs of the users. To help ensure patient data remains secure, all data is encrypted with AES when not in active use. All communications between the tablets and master control software is encrypted and will use the local wireless network using a configurable dedicated port. The master control software can be configured to send encrypted records via a web-based API. MASS can be programmed to communicate with an electronic medical record in order to identify and select scheduled patients who are recommended for or who are due for a behavioral health screening. MASS is currently programmed in 3 languages: English, Spanish, and Creole. Users are asked to select their language of choice to begin the screening and are given a barcode at check-in, which they can utilize to log into the screening software. Once the user confirms their identity, they are provided with information about the purpose of the screening and are also reminded their responses are confidential, just as any other health information that is provided. This information is provided both in text and in audio form. All screening questions are also available in audio form. Users can press the play button to hear items as the text and answer choices are highlighted as they are read. Answer choices appear in different shapes and colors to aid users of low literacy levels in providing accurate responses. Users touch the screen to select their answer choice, which will appear marked with a check mark. Once an answer choice is made, a next button appears on the screen. The user can modify their response if needed and then touch the next button once they are ready to continue on to the next item. Each screen has several control buttons, including a previous button to return to previous items and audio controls to adjust the volume. Once all screening questions have been answered, the user is thanked and informed that the screening is complete. MASS 2.0 is currently under development and is expected to be available summer 2019. Several software upgrades are anticipated. For instance, video instructions will be utilized to provide users with tutorials for how to utilize the software. The upgraded version will include master control software that reception staff can access from their desktop computer and utilize to assign a language of preference for the user. The receptionist would then direct the user to the appropriate touchscreen device or tablet so they can initiate the screening. This will be an added enhancement for non-readers. Another important upgrade will include modifications to the audio version of the screening. Currently, the text for each item appears on the screen as the audio is read. The upgraded software will provide an option for an animated character to guide users through the items without the use of text. Instead, audio prompts and visual aids will be utilized to elicit responses. Graphics, such as calendars, will be utilized as answer choices for items asking users to report on the frequency of symptoms experienced. A slide bar will be programmed so that users can easily respond to items asking them to report the number of days they have experienced a symptom or engaged in a behavior over a specified period of time. Users will also be notified as they are making progress through the different questionnaires included. Creative graphics will be incorporated into the screening to enhance the user's experience, including energetic displays announcing the completion of the screening protocol. MASS has been utilized to implement toxic stress screenings into pediatric primary care practices. One site in Southwest Florida has utilized the software to screen over 2,500 patients during well child office visits. A workflow has been implemented within an integrated care setting where medical and mental health providers work in teams to respond to positive screens. Once a user completes the computerized screening, a report is generated and imported into the electronic medical record. Critical items are reviewed by nursing staff and providers are alerted accordingly. Providers work in teams to address identified needs. Providers may consult in the hallway as response options are considered, and the primary care provider may also complete a warm handoff to the mental health provider when further assessment or intervention is needed. The mental health provider works with the family to develop the appropriate treatment plan and/or to make community referrals for additional services. An evaluation of the MAS software is currently underway. Preliminary findings are encouraging and indicative of the receptiveness of both providers and families to computerized screenings.
All right, so it gives you another type of solution. Now, what I want you to pay attention to with that solution, which is in the Immokalee area of southwest Florida, I've actually visited that clinic a few years ago, is that they're tailoring. You see the emphasis on the linguistic and accessibility components. It's because that area in which that they serve has many different languages that are spoken in that very rural area of Southwest Florida. And the literacy level is pretty low in that population. So they've had to tailor their particular screening solution to that population, which is why they're working so hard on the linguistic components. Another key piece that you want to consider when thinking about screening processes for your particular setting. It is very difficult, especially if you have a multicultural population, to just drop in a standard tool and say, here you go, this is going to work for everybody in every setting. So pay attention to that key piece. All right, last video here before we jump into our conversation comes to us from Jody Nudelman, and in the background, Dave Haddock, CFHA members. In this solution, you're going to see an approach that uses remote screening. So using smartphones as a screening device. So let's roll that one.
Hi everybody, my name is Dr. Jody Nudelman and I have been a psychologist for about 25 years. I also serve as the Chief Clinical Officer for Psychoanalytics, where we've been developing a practical at-home screening and triage solution that's cost-effective and intended to support universal population screening for behavioral health. We all know that we need population screening for all of the reasons listed here. A recent systematic review of psychosocial assessment tools used with 12 to 25-year-olds reinforces the fact that there is growing acceptance in the greater population for self-administered questionnaires. Broad, private, and primary care integrated screening destigmatizes behavioral health and clarifies best pathways. Smartphone administration increases feelings of control and personal reflection in the disclosure of thoughts and feelings. Data is gathered in an organized way and with less pressure prior to the time-limited physician encounter. As an example of what this questionnaire looks like on a phone screen, providers do not need to be spending high-value face-to-face minutes doing this sort of screening and results analysis. In fact, automated screening is broad, minimizes human error, and in most cases is billable. So doing this really is the first step in intervention anyway. Screening primes and activates patients. Ultimately, it enriches the clinical utility and the quality of the follow-up encounter. We also built in automatic branching sophistication. Screening layers in more granular items on top of prior items that triggered the domain's sensitivity threshold. Patients reveal details that are most important to them, highlighting areas for improvement. We know that patient contemplation leads to behavioral activation and increases overall self-care engagement. All of that has a strong influence on positive medical outcomes. Here's what the one-page assessment output looks like. This is designed to be an at-a-glance patient snapshot in a PDF document uploaded to the chart. In the near future, when EHRs become more interoperable and parity and integrated care become more viable, the human-readable PDF can be paired with a CCDA format that will allow for more sophisticated use of data for risk and trend analysis, population health, and even for AI applications. This is an enlarged view of the top quarter of the report. There are basic patient demographics and an alert section that identifies pressing, critical, important factors. Here's the meat of the matter. So whether you're a fan of focusing on specialty care or not, these symptom profiles represent potentially impairing issues that require attention. At this point in healthcare, more providers understand that psychological and behavioral problems often co-occur with medical problems and convolute or complicate differential diagnoses. By mindfully collecting this data and collating it on the front end, our aim is to facilitate primary care teams in streamlining communication and accurate referrals. The translational nature of the document also minimizes harm along the care path as patients move through levels of care with different providers. Here's the bottom section, and it clarifies context and social determinants of health. If these factors are not taken into real consideration, whole person care is not accomplished. In fact, missing or dismissing this information deepens chronic conditions. This is really meant to activate the entire care team and connect patients to the appropriate interventions. And finally, the key feature is that the assessment is portable and HIPAA compliant. It is designed to be easy for both patient and provider while improving the precision of triage and decision making. We're happy to explore our solution with anyone further, so please just be in touch. Thank you so much.
All right, so you see there an implementation that uses a smartphone and uses a link that a patient uses to fill out a screener. And you see some more sophistication that you didn't see, for example, in the implementation that I had, where you had something that automatically populated a PDF into an EHR. And as I noted in the comment, that's one of the key issues that you ought to think about with screening, because in your screening processes, you have to think about the data. Where is that data going to flow? How is it going to flow? What kind of work is going to be necessary to make that useful? And certainly one of the areas that I wish our major EHR vendors would work on is interoperability and the APIs necessary to get that data in, because currently many EHRs really don't make it terribly easy to bring the granular screening data in. Bringing a PDF into an EHR is still somewhat problematic. All right, so thank you to those folks who submitted those videos. Again, I think as a general comment, I would say that one of the things that each of these had in common is that they all focused on process automation. They all said the way to get screening done effectively is to offload the work from individuals on the care team to automated processes on the back end that make it easy for a patient to enter data and provide that data. And then a report that's easy to take a look at, assess, and evaluate pretty quickly, and then some mechanism to get that data into the EHR so that it's recorded, so that you have as little as possible human effort needed to either initiate and or make that process work effectively. Now, the other thing that I think, as I started out the conversation today, that's important to note is that implementing any of these things, I hope that you can infer, is not just a sort of start today, finish tomorrow type process. In other words, it really takes a series of PDSAs to make these things work in your setting, to implement them effectively. And you're going to need staff involved at the implementation stage, just like you would for any good implementation program, from your operations. You're going to need folks at your clinical operations. You're going to need some of the key leads in your organization to be involved. You're going to need to get buy-in from your care teams and your provider teams around the instruments and the utility of the instruments. You're going to need your tech people on board, of course, to help with facilitating all of the transition components of the technology. So you're going to need to run several PDSAs to make screening work, which is why I really encourage folks to think very carefully about the organizational bandwidth they have at the time at which they're screening. I've seen many screening efforts fail because the timing was bad. The organization was involved in a bunch of other integrated care program development or other sort of program development issues in the clinic, didn't have the bandwidth to give to the screening solution. And it wasn't the screening solution's fault that it failed. It was really just bad timing. The organization didn't have the bandwidth. It wasn't good timing for them to work on it. So think of this as an organizational change pathway. Think of PDSAs that you'll have to run in order to implement this, and think about the personnel that you will need to integrate onto your implementation team to make these solutions work effectively. So that's one of the things I want to bring up here. The other thing is I want you to think about your goals with screening. What are you trying to accomplish? What are your care teams trying to accomplish? What are you trying to change about your practice as it is now? What should you see improve as a result of this screening process? That's where we get back to Alan's point about the three-world view, right? So if you think about this as a comprehensive change effort, and you're thinking about the clinical sphere, you're thinking about the financial sphere and the operational sphere, what are you expecting in each of those areas, including, as he noted, the financial sphere? Like, how much is this going to cost? Are you going to be billing for this? If so, what's your model around that? Clinically, what are you going to do with these screeners? How are you going to use them clinically? How are you going to use them mostly at the point of care? Are you going to use them more as a population health strategy to monitor a population as you would in a registry? What are your goals in each of these areas? And you should really be outlining those goals in each of these three worlds in order to fundamentally then integrate screening effectively. So again, the bottom line is a lot of times screening efforts fail, not because the screening is a problem, but because the organization is not preparing itself effectively for what the screening is supposed to accomplish. All right, that's enough of me. Let's talk about you and what's going on in your worlds. So what I'd like you to do, either just, we're a small enough group that you can just talk or put in the chat. Do you have, any particular pain points around screening that you want to troubleshoot today? Any questions related to what we have talked about today, and or any success stories? Because we've talked a lot about barriers and some of the needs, but it'd be nice to also talk about the many success stories that do exist out there around effective screening strategies. So I'll open it up to the floor.
Dr. Serrano, I'll just jump in and say that we had some issues with screening because we're all telehealth in rural Colorado. And so we have lots of issues with how to get patients the screens and so the BHC can see it and the PCP. And so one of the solutions that hasn't completely helped us 100%, but it's helped a lot, is we got a hold of Peer Assistance, and they have their SBIRT screening that they give us in like a PDF form, but it's bubble. It's like the patients can click on it, and then it sends it back to our EHR system so that we're able to upload it. So the way that Peer Assistance had to send us that separately as a like specifically for our clinic. So our clinics, our 3 clinics. So if there's anybody who, wants to reach out to them and see if they can help, but they were able to do that for us, and we were able to put that into our EHR. So that was helpful. I mean, we have some other kinks to work out, but that was something that was a pretty good fix.
And just to clarify, is Peer Assistance a vendor or a person?
Yeah, so Peer Assistance is an organization that works with expert screening and training. And so they train, and they all work off grants. So they do all their work for free. So we haven't had to pay for anything, which has been great, which we love because we're grant funded too. But yeah, so they're an organization that leads workforce training, development, and education. And so their specialty is all expert stuff. So yeah.
Great. Yeah. And that sort of iterative work on screening is what is sort of the norm with it, right? You may start with a particular solution and then iterate your way through how to make that solution work. So in your case, it's really as simple as a PDF, right? An editable PDF is what you're talking about. I'm curious as to how they figured out a way to send that data back into the EHR and all of that, but that's the kind of workaround you sometimes need when you do have low budget and you need a quick and dirty solution for a process, right? So essentially, Tiffany, if you can highlight what is it you're improving in that setting compared to, I guess, if you're in telehealth, the only other option would be a verbal administration, correct?
Yeah, so the thing that we're improving right now is being able to get the BHC and the PCP to be able to both see the screen in front of them virtually. So that was the problem, was we didn't have, before being in rural communities, it was all paper. We didn't have anything virtual. So now they can both see the screen because we were able to upload it to the EHR, but that was hell because we had to figure out how to get that uploaded. So that was a lot of phone calls and tech stuff and how to figure that out. And so they're both able to see the screen now when it pops up so that they can reference back to it. But it's mostly our BHCs that are looking at the screen. The patient is filling it out through the portal. So we had to send it through the portal, through the telehealth portal that we also had to get creatively custom made and ask the people who help us with our telehealth to get that screen uploaded, which sounds like it was a lot, but it was a little bit easier than I'm making it sound. But we did have to figure that piece out so that the patient before their appointment can pull it up, hit send, and then it sends to the telehealth. And so it's a separate process from sending it from the telehealth program into the EHR, because our telehealth and our EHR are two separate, which growing pains, right? So we're working through that.
Great. Well, thanks for sharing your story. I think that's important as well to note that telehealth has changed things somewhat. I know in the clinical setting that I work at here at UNC, I've definitely noticed that screening has gone down because when we switched over to mostly telehealth, now it's both, but there wasn't a ready-made telehealth screening solution. So all the protocols that we had in clinic did not transfer over to the telehealth sphere automatically. It is possible in our portal to send a patient a screen. But there was never any training around doing that, and it's not automated. In other words, I, as a provider, would have to specifically send a patient a screen through the portal for them to fill that out. And I'm actually not even sure how I would be notified if the patient filled that screen ahead of time. I'm assuming there's some system for that. But again, it just shows you how systems, if you don't adapt the systems, like you just can go nowhere real quickly.
If I can jump in there real quick, I mean, there's lots of ways to automate that entire process. So what we end up doing in most of our work is we generate a link or whatever you need, and we can send it out through whatever system you need. And you actually, what we found is it's almost like like you're doing an email campaign in that you actually do follow-ups. And so essentially if you do fully automated, at the time you schedule inside your EMR software, basically that is enough to go, oh, what type of visit are you going to? Where's the clinic at? And basically age usually, or enough of that can get you back to what exactly are you going to do in terms of the screening protocol that you're going to use to get information back. So what combination of things are you going to do? And then when you get through with all that, that gets done, and then you can basically all EMRs and actually most medical systems are all supposed to use a common language called HL7, which allows you to transfer information between disparate systems. And so at a minimum, a system, an EHR or an EMR will have HL7 capability and so forth. And so inside of that HL7, you have the ability to break out all your data fields. You have the ability to break out notes, and you have the ability to actually send the PDF itself. And so you what they call base 64 encode the PDF. So you can just take the PDF and just send it in electronically. And then it automatically comes up, sort of idea. And so if you do the entire automation, this whole process, then everything can show up back where you want. The other things you can do across these, and we did this up in, if you're Colorado based, we did this up in Grand County. We actually went to across the pediatric world in terms of screening and got every single screening location in the county. So we're up to like 90% reach inside the county and so forth. And we basically set up a system by which if you profile, connect patients in between disparate systems, you can just pull up whatever information they have in either system. You can run it in and out of your EHR and all that kind of stuff. So it's really all, there are automated processes where you can get by all this. What comes down to a lot of times inside of EMRs, and I kind of noted this at the end of my little clip there, was that your problem on the inbound side and coming in as lab data is that your EHRs are not even set up with the proper storage to be able to say, oh, I want this specific data field. I mean, people can't even agree on that kind of stuff. And so what ends up happening most of the time is we create a summary note. So it'll actually just list out all the different things that you've done and so forth and say, okay, throw that in and throw that on the encounter tab. And so inside of there, you flag and go, oh, you're out of range on this, or here's a flag on this, or here's something else you need to look into. And so it's right on the encounter tab at the time the provider's working with the patient or anybody who's pulling that up. And then off of that, you can go, oh, okay, something's out of range. I want to look deeper. Then you go in and you actually, wherever the documents are stored inside the EMR, and they're different inside each one of these. And so we've run interfaces to all the different EMRs and all that kind of stuff. I mean, that part of it's actually easy. The problem is actually how do you store it inside the EMR itself? And so a lot of times if you have manual, if you're already doing it where you can enter it manually, then you probably have storage inside that EMR and it's just a matter of getting it hooked up. What we're seeing now is more of, we get into a lot of the, like the Greenways and the Athenas and stuff like that, where they're actually have a centralized in the cloud sort of EMR, and you can just have a common API interface that allows you to do the same sort of stuff, sending out and sending back in terms of scheduling and routing back in. But what you really want to do, if you really want to get it right, you automate everything associated with getting in and out of that EMR. And if you're in a fully automated system and you're using remote via text or email or whatever and getting your data in, you can literally do the entire process without getting staff involved. It just shows up in your EMR. And so that's really what we're about. We don't do content. We don't care what assessments run through the system. We're all about how do you do this automation. And so, if you ever want to try to dig into it, and we can show you how to do that, we've done it with a lot of different systems now, but that's the real trick to this whole thing is get that automated movement of data, get the data where you need it, and don't have to rely on staff at all to get the process done.
And, that's interesting. I hadn't thought about because I've been blaming the EHRs for most of my life, for most of my problems. So maybe I just got used to doing that, but I didn't realize that there was that baseline flexibility. But it makes sense to me, given what I've had to work on over the years, that some of the issues actually might be on the end user side. So if I understand correctly, let's say I work at UNC and, we've got some data, external data that we want to import. Technically speaking, that EHR has the capacity to do it. But what you're saying, it would take some work on our end to actually develop the storage fields where that data would go. And so I'm guessing that some of the issues that some of us have run into is that organizationally, we can't get our people to do that for us.
When we do an EHR interface, that's actually the hardest and the most time-consuming portion of it is actually figuring out where you're going to store the data. The mechanism for getting in and out is easy. I mean, from our side, it's just configurability. I mean, we just point and click and we move the data where you want it. We can set the PDF in as just a single field that goes into the EHR. So that's really not your issue. And what you see a lot of times, because it's so hard to fight that battle, what you find is that people actually roll back to, oh, just give me a summary note and I'll do that for the actual process. But if you want your data, a lot of them just use data warehouses. So we'll just throw all the data in, throw it into a data warehouse. And if you want to get to the discrete data and you go and do analysis, usually you do both those interfaces going and so forth. And so it really comes down to what are you trying to do with the data in that particular arena. So if you are getting into the data side of this thing, I would recommend don't try to fight the battle at the EHR. Go ahead and just get into a data warehouse. You can get all your data fields in there, do your analysis there. Just pull into the EHR what you absolutely need to get the patient taken care of.
Great, that's helpful. And just to do a little bit of interpretation for the less techie members of the audience. So basically what this looks like is, in some implementations, is instead of bringing the data field by field into an EHR, what Alan's talking about, you may bring in the PDF, you may bring in an encounter note that comes up in your encounter tab with a summary of it, of what's happening, flagged, et cetera. But then if you want to get into the data, you may have a separate portal. Often it's online, with a secure website, and you can get in there and view or download your data from that what's called a data warehouse, and do any analysis that you want to do with the data from there. So that would be, for example, the benefit of that would be if you're doing some population-based data work, right? So if you're taking in your screening tools and you're saying, hey, I want to track my population, I want to get some population statistics across patients, you'd go into that data warehouse, pull that down, and do whatever analysis you want on your population.
Yeah. So I'd just like to add to that. I certainly agree with everything Alan said. I want to point out, though, that the 21st Century Cures Act has forced the EHR vendors to support interoperability. They don't always support it willingly or gladly. But the real problem is, if you're going to do any sort of population health statistics out of your EHR, there is no discrete location for all the data that we can collect. And the data we collect is really, really valuable data because it's real-time data. It's not historical data. It's fine-grained. It covers a lot of different areas of mental health, behavioral health, and social determinants of health. And there's no place to put that. So for the smaller clinics who don't have data warehouses or the ability to support this sort of work with a good IT staff, we have to keep that data ourselves and then pull reports for them to support their need for population health. Because in its FQHC, it governs how much they're going to be reimbursed. If they know the severity of the different conditions in their population, they can use that data when they negotiate your PPS rate every year.
Right? Yeah. So just to clarify, what you're saying is you really wish that EHRs were preset to receive this crucial data.
Sure. Well, if they handle blood pressure and lab reports, right, all in a very discrete way. If I want to know the liver enzymes for a patient, I can just look at a graph that shows me liver enzymes over the last 5 years. Okay, right. And we should be able to do that for mental health and behavioral health and social determinants as well.
And you still get into this issue of whether you're doing analysis or whether you're doing management, I guess is the way to think about population management. We have a dashboard that we put out so that you can actually go pull the data right off our servers to do it and so forth. Mm-hmm. We find a lot of people are actually interested in the data that they actually want to copy down low inside their own organization. And you can do that very easily. I mean, you can just throw it into a simple standalone database. You even throw it out in an Excel spreadsheet. I mean, if you really want to pull all your data, you can get it right down. But then you got to know a little bit about how to manipulate inside of an Excel in terms of frequencies and stuff like that, which isn't tough, but it really comes down to then what are you going to use for your analysis tools, whether it's going to be prepackaged for you and so forth. I mean, if you do it in a dashboard, you get basic frequency tables, but if you really want to look at your data, you better know how to run SPSS or something like that.
Yeah, and that brings up another key piece here that, and this is sort of a bigger issue with EHRs in general. we actually have a whole lot of data that we don't do anything with, including a lot of our behavioral screening data. So one of the things I want to put in all of your thoughts today is thinking through strategically about screening. When you think about a screening process, you may think very small, right? And that's good. You want to start small with small PDSAs. Maybe you're going to start with just a PHQ-9. That's fine. But think about screening as an incremental process as you move along the continuum of true integrated care, which really is about the same sorts of goals that the patient-centered medical home has, about good population-based care. Because eventually, what you should have is an organization that is a data-aware organization. And that organization begins to make decisions about data because it uses that data effectively. So one day, and I don't know when that's going to happen, but I think sometime soon, especially as we move towards value-based payment schemes, as we move more towards a population-based health mindset, screening will become part of not just patient identification for particular conditions, but actually what's called risk stratification, right? Where you are beginning to identify the vulnerable patients in your population more proactively, tracking those patients proactively, intervening with those patients proactively with a diverse set of interventions and strategies across your population. And you're going to be using your care team in very creative ways to make that happen outside of just even an office visit, right? So there's a continuum here, and the paper and pencil screen that we have all grown up with is just the beginning part of that process. If you go down this road of automation, of using your data from not just at the point of care, but also from a population health standpoint, you will end up at that location where you have a data transformed organization with a sophisticated risk stratification process, so that you are essentially using data to map out your entire patient population and then using your care team to strategically intervene with particular portions of that population. So to your question, Tiffany, about data warehouses, that's where you would get that information. And almost every company that I've come across that has some sort of automated screening solution will either offer their own cloud-based service where you can access that data, your data basically. So if you're processing the data through them, they will just house that data, and then they have a website you go to, you log in, and then you can download that data. In some rarer instances, the company can set a server up for you in your own, if you have a big IT staff usually, and, set up your own server and your own data warehouse that's proprietary. Only big institutions usually host their own things like that. But at the very least, most of these companies will give you access to your data. And you, as Alan said, you pull it down in an Excel, and then you do what you want to do from an analysis standpoint. So data warehouse is just a fancy tool a fancy word, way of saying a place where your data lives, on a server or on the cloud.
Yeah, that makes me think of the registries that we need to do for our HRSA grant reporting. And the problem we're having is all the data that we have, we're having to double chart because we don't have a way to get the data from the EHR to a registry, or to, like Alan was saying, that spreadsheet, which we would essentially see it as a registry, move it to the registry that we have. So we have Dr. Chrono EHR, which no one's really heard of before. And so they don't really have, an option for that. So we're really struggling with what to do, how to get the data that we need so that our people aren't double charting, right? Like in the EHR, and then they have to chart it in the spreadsheet. So this is really a really helpful discussion. I really appreciate it a lot.
Yeah. And, double charting and double entry is one of those pain points that, especially in my early days, was a huge issue. And again, that's where I think moving towards, and all the vendors that we've seen today, move towards solutions that don't involve people or involve staff as little as absolutely possible. And on the patient side of things are easily accessible and appropriate to your patient population. population, right? So again, you see, we wrap up here. I hope you can see that it really takes some effort to think about this. This conversation has too often been reduced to trite conversations around, should we use a PHQ-9 or a PHQ-2? And it's a lot more involved than that, right? I mean, you have to really think about this from an organizational transformation standpoint and create plans and PDSAs around this entire process, and keep that big picture in mind, that whenever you start with a small screening strategy, you're really going down a particular road of transformation that really should lead you to these larger organizational initiatives. And in fact, that's a way to sell this to your organizations. If you're interested in this, and if you're just trying to sell a screener to your organization, you're probably going to fail, right? You have to put it in the context of how this is strategically important for our organization. And there is a pathway that leads right down to value-based payment, risk stratification, the big picture items that most, at least large entities, are going for. Now, you still have to, and we'll end with this here, you still have to keep the care teams in mind. And this is a piece that I honestly haven't figured out especially well, even in my work in my 20 years. And I hope we can, as a community, do better with this. Is my sense so far has been, as far as utility, I think screening tools in general probably have greater utility as population health strategies than point of care. At the point of care, getting your care team to be invested and to use that information effectively, that's tough, because every patient visit in a primary care setting, especially, but it's true of other settings as well, is a very unique visit, right? So if you have a screening tool that's been filled out for that particular visit, is the information in that screening tool going to be applicable to that particular visit? Maybe like 30% of the time that might be, right? Because you might be having that visit for something else. Now, I think the information's important, but it's not necessarily applicable to every single visit that you may have with that individual, right? So you can imagine, say, a person for whom that visit is really strictly back pain, but you got this really good, helpful information, and it may hopefully trigger and inform, hey, we got to make sure to stay on top of this person's depression, bipolar disorder, whatever it is that we've screened for, or we're aware of the social determinants here. That's all well and good, but it may not be applicable to that particular visit each and every time, right? So I think that's one of the tough nuts to crack, that screening is applicable to many visits, just not all visits. And therefore, sometimes care teams struggle with valuing the screening at the point of care. So just one of the things to additionally think about. All right. Once again, I want to thank Alan and Smart Tools, Dave at Psychoanalytics, and the folks in Florida, Javier Rosado and the Mass System, for presenting some of their stuff today. This is going to be up on our Integrated Care news site. If you want their information, they've already given it to you, but if you missed out on the ability to get their emails, we can easily make their emails available. Just let us know. You know how to get a hold of us. Thank you very much for this community conversation. We'll see you at the next one.
Sounds great. Thank you.